The first slide is my disclosure slides, and you see that I'm doing a lot of consultancies for scleroderma, fibrosis, and related complications, including a lot of fibrosis, lung fibrosis. And I think this is my bias. I'm talking, of course, I'm talking on autoimmune ILDs, nothing with IPF. Right? No idea what that is actually. So I'm not only talking about the PPF. I understood it as in general progressive ILD in general. So this is for everyone to remind, and I think Lukas gave you a very nice overview of PPF guideline criteria. And mentioned that the lung function tests are the most meaningful. So that's why they're also looked at it separately as a definition of progression. And the PF-ILD inbuilt criteria are mentioned on the right, just to set the scene. And Luca, I haven't included this in the presentation, but we've just submitted a paper to Blue Journal confirming what you showed in the scleroderma ILD. The progression is driven by HRCT, plus lung function testings, and the symptoms are, not to say useless, but a little addition to it, as you've shown for a wider cohort. But that's not what I want to talk about. So in the autoimmune ILDs, is progressive fibrosis as a general term, how frequent is that? Are we seeing it frequently or not? This is from a paper that we published from the USTAR cohort, and the USTAR cohort is a big cohort. We have now 26,000 patients in the cohort. 2/3 of them are followed longitudinally. So that is really a huge cohort. This is a while ago, and we only included patients where we had 5 years follow-up annual FVCs available. That's why the number is relatively small with 826 patients. But these are all comers. So they are in a rheumatology practice. If they have HRCT positive ILD, they were included. So this is all kind of patients, all kind of, standard background. The registry is 20 years old, so this includes older patients. Many, but not all, have been on MMF. Others have not been. A few have been on biologics in more recent years. And what this shows you is that a stable 30% roughly of patients are developing progression, defined here as FVC more than 10% or FVC 5 to 10%. So liberal definitions. 30% in a standard of care, all-comers scleroderma ILD population. And when you look at that over the years, actually it's cumulating to almost 70% of patients that show at least one progression period of 1 year, where they progress within a year. So within 5 years, then we have 70% of patients with scleroderma ILD progressing. Quite a lot. Huh? So that is frequent. I think we can agree is frequent. And when we look at other autoimmune ILDs, for example, Sjögren's, MCTD, IIMs, or RA ILD, we do see a similar pattern, huh? Depending on the definition, what you're using. If you use, for example, the PPF criteria in red, it's about what you see here, the numbers, but they are relatively uniform across the different underlying autoimmune diseases with some differences. And of course, it's making a difference if you use FVC more than 5 or FVC more than 10% decline. But I think it's a frequent event in autoimmune ILDs. I think that is a safe conclusion from these data. And this is interesting because we were wondering, when does it occur? There's a kind of belief that you should follow up in, when there are more stable patients, you should follow them maybe annually. If earlier, every 3 to 6 months, but nobody's really saying what now. And this plots the scleroderma and RA ILD patients from the census and the inbuilt, because there you do all these frequent follow-ups because they're part of a study. So they get an FVC every few months or weeks even. And here you see something I think that is interesting, and it's underlining how important a frequent check on those patients is. After only 12 weeks, 3 months, 16% of the census population and 23% of the inbuilt RA population already had a progression event. And if you look at 6 months, actually, it's 25% and 40% that already had a progression. So there's a continuous linear increase in the number of progression events up to a year. And of course, if you wait for a year, because the patient might have 7 years of disease duration, you're missing a lot of progressive events. over that whole year. So frequent follow-up is important. And it continues over time in scleroderma ILD. This is again from the U-star cohort. We looked at when are these progression phases happening, because there's a belief that in the autoimmune ILDs, this is all happening at the beginning. It's actually not, as you see. It's a little bit more frequent in early disease and short disease duration. So when you look at the 0 to 3 years of disease duration in dark blue on the left with different definitions, it's a bit more frequent, but in a disease duration of more than 15 years, you had 12% of patients progressing within a year with that definition that we used here. So it's not real, it's not disappearing. I think the mortality of autoimmune ILDs is coming because of the continuous decline that we do see in these patients. It's not burning out, it's not disappearing. So stay alert is the message here to screen for progression. Is it meaningful? It is. I've listed 2 examples here. So autoimmune, the scleroderma ILD in the SLS1 study, if they only had on the QILD score as minimal as 2% progression during the study, at long-term follow-up, this translated into a very meaningful difference in mortality, as you see here. In red, those that are not progressing, in blue, the ones that are progressing, but only 2% on the QILD score. So that has definitely impact on long-term. So it's predicting a bad long-term outcome. And the same, if you look at the PF-ILD criteria, you see that even that is predicting in a small cohort in the Zurich and Oslo cohort, long-term 3-year mortality significantly predicting. So a single episode of progression is translating into long-term mortality. That's a hard outcome. And only 3 years, that's relatively short. So I think we also can agree, progression is important. It predicts long-term outcome. So that is the reason why that is a frequent inclusion criteria in clinical trials. It's even, that we are contacted, we want to do a study in progressive fibrosing ILDs. Can you consult for us on the autoimmune ILDs? They're not even asking, should we should we include progressive patients or so stay? It's only on progressive patients. The discussion is so lively. The clinical trials are only designed for progressive ILDs at the moment. So as a result, all medications are approved for what it has been studied for progressive ILD. And this is creating an issue. Imagine your clinical situation. You're sitting in front of your patient, you're having this HRCT here, shortness of breath, and then you're saying, now we have to wait for progression because you have to wait until you're even worse, because only then you're getting the medication because it's only approved for that indication. That sounds strange, right? And I think it is strange. And I will give you some arguments why it's even more strange. Because what we think, why are we waiting for further progression or damage before we start or escalate treatment? Why are we doing this? Well, because I think the argument is progression identifies patients who will further progress. So they are the ones at highest need of these expensive therapies. And that's why the agencies and payers around the world are limiting that to the patients at highest needs, because they believe there's someone progressing is further progressing. And that's the reason why this is an inclusion criterion in the trial. That is why the trials are designed like they are. So is that true? So let's look at, again, the same paper from the U-star cohort published a couple of years ago. What you will see is, in red are the ones that are, we had this before, that's difficult. In red on the left side are the ones that are, doesn't work. In red on the left side are the ones that are progressing in the first year. And you see that in the second year, 112 of them in green are becoming stable. And only 21 are progressing in the second year. Let's look on the right side, the 389 in green that are stable in the first year. Of them, 118 are progressing in the second year. And you already get this impression that this is not a continuous decline in the majority of patients. If you follow the red line on the left, 146, 21, and only a single patient that is has continuous decline over 4 years. So that already indicates you that is not coming in as a continuous decline. It's coming in phases. There is a period of progression, and there's a period of stabilization in many patients, and then there might be another progression later on. So it's not a continuous decline. So to further look into that, we used the Oslo and Zurich cohort, and this is shown here, just published this week actually in Lancet Rheumatology. You see in the first year, again, we do see that distribution that we have identified before. 70% are progressing, 30% are progressing, 70% are stable or have a slight improvement. And then in the next, but the ones that have been progressed in the first year, only 20% are progressing and 80% are becoming stable, which is higher than what we see with the patients that we would expect them. So this indicates actually that a recent progression in the last year, this is more or less what we are using to define progression, is translating in a lower likelihood to progress in the next year. And this can be looked at in multivariate prediction modeling. So what you put in here is the different risk factors for progression, and you see that a decline of as little as only 5% in the recent year is a statistically significant negative predictor of progression in the next year. Now I see already Artol is saying, I'm waiting for your questions. So you presented this at conferences, and people were saying, it's Oslo and Zurich, you do something wrong. So we extended our analysis to Michigan, because our US colleagues were also saying, no way, right? But you see that this is holding very much true. If we include the Michigan cohort, an early disease cohort with shorter disease duration, actually. It's again holding true. It's independent of immunosuppressive treatment. It's not a regression to the mean. We looked in the different quartiles, quintiles even. This pattern is true if you're in the uppermost quintile of FVC or the lowest quintile, independent of where you are. It's not regression to the mean. It's not depending on immunosuppressive treatment that you induce, because it's also true when we look at those patients that where no immunosuppressive treatment is started. And then we looked at clinical trials, because people are saying cohorts are not clinical trials. When we look at the census cohort presented at ERS from our colleagues, you see the very same pattern in scleroderma ILD. A progression in the first 6 months in the census trial is associated with a lower likelihood of progression in the next 6 months. So here's something wrong. Huh? We are now waiting for further damage progression before we start or escalate treatment. And then we treat patients with a lower probability of short-term progression. I'm not saying long-term, because the long-term outcome is bad. It's associated with survival. I'm not saying that you should start thinking about treatment when there's progression. That is not debated, because the long-term outcome is bad. I'm strongly questioning whether this should be an initiation to start or escalate treatment in clinical practice. And at least for scleroderma ILD, I'm questioning if this is a good enrichment criteria for clinical trials. So further studies need to look at ILDs in others than scleroderma, obviously, to confirm that, because that is scleroderma data and other data have not been looked at, to my knowledge. And it's not only my opinion that this may be not the right thing. This is the ERS-EULAR guideline that actually Katharina is first author and will be published very soon in ERS and ARD. And when you look, there is progression mentioned down here. So if there's ILD progression not controlled, then indeed think about combination therapy, add monotherapy. So this is, you're doing all right. But we are not doing all right to start or initiate treatment only when there's progression. This is wrong. So whenever, in my opinion, whenever you can treat or escalate treatment, do it. And if a patient has risk factors for progression, there's no indication for treatment included. So you may analyze whether there's almost no risk of progression, whatever that is. But if there is a high risk of progression, this even suggests a combination therapy of immunosuppressants, nintedanib and MMF, or we take the inclusion criteria of the clinical trials as an indication to start treatment. So for tocilizumab, for example, there's a progressive inflammatory diffuse scleroderma population, you should start treatment. In our opinion, you should not wait for progression. And progression was also not a criteria in these clinical trials. So in 10 years, you know, the title is what PPF in 10 years. In 10 years, back at the 15th then Share Congress, I think we will see this year. Gone but not forgotten. It's important to consider for data, you know, when there's progression, you should do something, bad long-term outcome. It was helpful as a vehicle, but I think it's overappreciated and misused currently. And we should do clinical trials not only with PPF patients. I think we should do clinical trials with patients at risk of progression. Thank you.